Welcome to Healthcare Algorhythm. I'm Dr. Will Strimel. If you want the real story behind today's healthcare challenges and the strategies and technologies people are actually using to solve them, you're in the right place. Short conversations, clear insights, practical takeaways. Let's get into it. And hello, everybody. Welcome back. It is Dr. Will Strimel. It's a pleasure to have you back here on the Healthcare Algorhythm. And it is also a pleasure to be joined today by Aaron Nye. Aaron is the Chief Operating Officer of Connect America, which is one of the largest providers of personal emergency response systems and remote monitoring solutions for older adults in the United States. Aaron, thank you so much for joining us.
Thank you, William. Great to be here. Thanks for having me.
My pleasure. And you have really been operating at the tip of the spear, really, when it comes to the interface of technology and patient care, especially in a way where the stakes are high, right? Because you're dealing with a lot of emergencies situations. So I'd like to begin by maybe just having you tell us a bit about Connect America, what you all are working on right now, and how you became involved.
Yeah, so Connect America, like you said, it really is the tip of the spear. I mean, we're helping seniors age gracefully at home. And so when you think about your average senior, our average customer, 83-year-old, usually a woman living alone, might have a history of falls, probably one or multiple chronic conditions that they're dealing with. And over 90% of those seniors want to age in place. They want to stay in their home rather than move into some assisted living facility. And so we help them do that, and we help them do it safely. So we've been in business for over 50 years now. When you look back, we acquired the Lifeline business back in 21. And so when you look at what Lifeline did and where it started, it was really born out of MIT. A few people had an idea that said, hey, it's kind of the same technology that opens a garage door, a radio frequency could trigger a phone call to be made. And so they said, hey, what if somebody had basically a garage door opener around their neck and they pressed it? It goes to a device that triggers the device to call one phone number. And that phone number would go into what was called back then a central station, which we now call an emergency response center. And at that point, the operator at the ERC determines the next best course of action. So really simple idea, and born out of that, we've got close to 1 million members, subscribers through the US and Canada that we monitor. And we've really grown the platform. We really are much more of a platform now than just one PERS device.
Yeah, I saw it was interesting to think it started as a garage door opener, and now, if I saw correctly, it's evolved into a smartwatch, which has so many capabilities, right? So how about yourself, though? Let me hear a little bit of what's your journey to get to be the chief of all this?
Yeah, it's I grew up in a hospital. So my parents both worked in a small rural hospital just outside of Pittsburgh, about an hour outside of Pittsburgh, a small town called Elwood City, PA. Probably I would say maybe a 90-bed hospital, and had the ED and cardiology and radiology and all the specialists right there in one spot. And it supported a community of probably around 5,000 people. My parents lived 200 yards away. They both walked to work. My mom was a MA in radiology for probably 20 years, and then in cardiology for another 25 years. She's still working to this day in a cardiologist's office. She's 67 now, actually. And my dad was a maintenance man, so he'd fix the boilers and do whatever needed to be done in the hospital. And so, from as long as I can remember, that was where I went to go grab lunch, or I'd broken my arm 4 times when I was a kid. That was the hospital where I would go to. I had 3 surgeries in that hospital on my arm, and it shut down back in 21 or 22, I think. And it really, you had hundreds of people that were employed there. People used to be able to go 5-10 minutes to get care, and now maybe they're driving half an hour, 45 minutes, or an hour all the way down to Pittsburgh to get care. And I think you see that all over the country, right?
Sure. Not just losing like the physical proximity, but the closeness of a relationship. That was as you said, you went to lunch there, right? So that was just that was a part of your day-to-day life, your community. And, usually what goes along with that is trust. And so I imagine that concept of trust permeates all through healthcare delivery, right? And I think it's one of the things that's harder to embed, especially in new technologies. I'm interested, right, as you maybe tell me a little bit about where in the patient's journey, there's probably where you most typically get patients who kind of become clients or customers of yours, probably much later than the ideal place they are. But, how are you meeting people? Where are they at when you meet them? And how do they feel about this kind of technology?
Yeah. On the we have two lines of business, right? Or we have more than two, but we have two main lines of business, and one is personal emergency response services, right? And so that patient, that member, is typically had an issue, right? They've had a fall, they're sick, something has happened for them and their family to say, okay, mom or dad has to get this device, and begrudgingly they start wearing it around their neck or their wrist. And like I said, that's usually 75 to 85 or so. Where we do start meeting them earlier in their journey is in the remote patient monitoring and the telehealth side. And so
Okay.
that patient is typically 74 years old, polychronic, right? They're going to have multiple conditions, and then we're going to ship them a kit. We're going to ship them either a blood pressure cuff or a scale, glucometer, or a pulse ox. And at that point, our nurses monitor them and make sure that they're staying healthy between visits. Yeah, we're healthcare is local, right? And we're trying to sort of get that same reach. It's the same nurse who's going to call you every week to check in on you. Start building that relationship and building that trust. But it's tough. We sort of I think RPM's got a bit of a bad reputation from some bad actors from during COVID times, but we're trying to get over that.
Now, what is that link? I think it's easier to see with the emergency stuff because I imagine if someone activates an emergency, that's going to be 911 or a similar type of response, first responder type. But in that earlier patient, that chronic care management where you're trying to keep them healthy, how are you connecting them to whether it's their primary care doctor? I mean, do you sit adjacent to them? Do you also forge a relationship with the people who are providing their care? How do you make that data seamless and actionable?
Yeah, that's a great question. It's something that we've been working on for the last 4 or 5 years, and I think we've finally gotten to a good place. Normally, we work directly with the provider, right? So we'll come in to let's say it's a cardiologist, and we'll say, hey, you've probably got a lot of patients that you might see every 3 months, every 6 months. You get a couple readings per year, but you don't really have a good look at what's happening between those visits, and we can kind of close that gap for you. And so we go in, we work with them to identify the right patients to offer this service to, and then at that point, the doctor will come up with all the care plans, and we'll work with them and the NPs or the clinical staff to figure out exactly who gets what types of devices, and then we'll ship those devices out. We handle everything from the consent, device shipping, activation, support, and then we have our own nurses that can also be eyes on the screen to go ahead and monitor those patients' vitals, make sure that they're staying within the thresholds that they've aligned, and then we'll reach out if we need to escalate anything to the physician. But we really try to take that point of separating signal from noise and just giving them when they need to act on something.
Yeah, so that's probably a great point to talk about the technology itself. And in a very short period of time, and we've come from like remote monitoring to basically mean blood pressure and your weight to think of all of the data points that can be sucked in from all kinds of wearables and our phones and whatnot. So I'm sure you all have seen a lot of data come and go and like this is going to be really helpful and it's not, or how do you separate the wheat from the chaff, right? With
Yeah.
all of this data that comes in. What devices are you using or what have you found to be most useful and what really makes a difference?
So the current devices that we're working with, right, are just the basic ones, and you can throw in a thermometer or something there that was
Yeah.
really popular during COVID, not so
Yeah.
much now.
False alarm.
Yeah, but for us, really the blood pressure cuff, that's like the workhorse.
Okay.
I think so many patients that we have, and what we've really seen, and you sort of see it with like United Healthcare and what they've done, walked it back. But originally they were, I think it was end of last year, they were going to switch the only a reimbursement that would come for remote patient monitoring was for chronic heart failure patients and prenatal hypertension.
Wow.
Yeah, and so they ended up rolling that back. I think with some pressure from DC, but it sort of shows you which way remote monitoring is moving. And I do think that chronic heart failure to me seems like the best path forward. I think it's a it's a $30 billion
Yeah.
cost to the system, and really 20 billion of it. Uh, is the non-adherent patients. It's really straightforward, right? All they've got to do is step on a scale once a day, and it seems simple, but I think
Right.
a lot of chronic patients, as you know, are chronic for a reason, right? They just don't have the right behaviors. So we're working with a company right now through a clinical trial, and the company is called Heartfelt Technologies out of the UK. And it's a really interesting device. It sits next to the patient's bedside. It's an ambient monitor. It uses LiDAR. It takes a look at the
And just
patient's
LiDAR, can you
foot.
explain what that is for the
Yeah, basically it's if you have any type of like not even a self-driving car, but just a car where, it's driving and something will go off if like somebody's coming in the lane next to you. It's sort of like local radar. It goes in a short area and it just senses what's in front of it. And so it uses that along with an image to put pixels on the patient's foot and ankle. And it can measure with AI the volume in that appendage, and very accurate. And all the patient has to do is just walk in and out of bed. So as long as they go to bed, you're going to get a measurement, right? And it just monitors that volume day after day, so that you can see when the peripheral edema starts to swell, and they
Sure.
might not be taking their meds for whatever reason. They hate going to the restroom so much. And so what it's seen, and again, a lot of the trials have been in the UK. We're just kicking off one in the US here, but it's been a very high reduction in readmissions and a usually about a 13-day intervention time, right? Before they would have had to go to the ED, that
Right.
they can
Yeah, so
they
I
can
imagine, you can pick up that signal, that's gonna trigger your team to reach out to the cardiologist in this case, right? Now they're gonna reach out, "Hey, have you eaten more salt? Are you taking your water pill?" Some intervention that they can kinda implement at home to prevent them from coming in.
exactly, yeah. And so even a little bit more than that, we've got chronic heart failure nurses, right, that will reach out before the doctor even needs to, just to make, we've got the plan of care. We work with the doctor on the plan of care, and we'll go through and just do that basic checklist just to make sure that the patient's doing everything that they need to do. If it has to be escalated, then at that point we'll get the
Okay.
provider involved.
So then at Connect America, you manage the relationship with with the providers and the patients. You might have the monitoring, and then you're looking out in the marketplace for the technologies that you think are making the most difference. Is that sort of how it works?
Yeah, basically we just we're device agnostic. So
Okay.
we have a platform set up. We've got our nurses, we've got our operators. We sort of just it doesn't matter what type of device it is, right? Whether it's a smartwatch or smartphone, or I'm looking at a spirometer right now, and
Mhm.
so that you have that, you integrate it into your platform, and then at that point the readings come through, and so we're not really tied to any types of devices. We don't manufacture any specific devices or anything, so totally agnostic, and so we can be flexible.
So I imagine if you are engaged with a lot of older adults, a big part of that generally is the family members, the caregivers. Yeah, maybe tell me a little bit about how you kind of triangulate those relationships or bring the caregivers in as part of the support network.
Yeah, we call them the care circle, and so it could be a neighbor, could be a family member, a friend. And so when we first bring them on through the intake process, right, we're trying to set up that what we would call a responders list. So what's interesting with PERS devices is normally you think, oh, they press it only during an emergency and only when they need an ambulance. It's actually a very small minority of our signals need to dispatch EMS.
Oh, wow.
Normally what happens is they're testing their device. It might have gone off by accident.
Okay.
Sometimes they just need somebody to talk to, right? They're just lonely. Some people, don't have anybody that they can speak to, and so our operators will just talk to them and make sure that everything's okay. Sometimes they'll press the pendant before they go into the shower, and they'll say, "Hey, I'm going to go into the shower. Call me back in 15 minutes. If I don't pick up, then I probably fell." And so then
Wow.
we'll call them back. Yeah, they were sort of that safety net for them. The most common intervention we have to have is just what's called a lift assist. where they've fallen, they're not injured, they don't need any type of medical help. They just need help getting up and getting back into the chair or wherever it might be. And so that's normally, we call one of their responders or somebody that's close, and they can come over and help them up. Sometimes you've got to call EMS. That might be the closest person, but normally
Listen, I
that's
can
like
tell you, I just took care of a guy today in the hospital who the reason he was in the hospital is he has chronic back pain, lost his balance, fell, spent the entire day on the floor until finally, and so that he's now had a 3-day hospitalization because of that.
yeah. I mean, you look at how many avoidable hospitalizations. I mean, everybody knows about falls, right? It's the chronic condition leads to a fall, and then the fall leads to the deterioration. You see it right there, right? It's a perfect example. And I think any caregiver or anybody who works in a hospital will tell you that that's one of the most common things. And if you can get in front of that, even if it's instead of they're on the floor for an hour, they're on the floor for 10 minutes, right? Something like that is going to make a huge difference. And I think we still have a pretty small penetration into the total senior market when you look at personal emergency response services as a whole, depending on the data that you look at, it's probably 8 to 10% of seniors have a PERS device. And I think part of it is that stigma, right? I need this. I'm getting old. I'm getting frail. And so what we're really trying to work on is a lot more discrete technology, something you would wear around your wrist that maybe looks like a Fitbit or something else that isn't around your neck and swinging around and everything like that. So we've seen a lot of success with that.
Yeah, so that smartwatch that I mentioned earlier, I saw that from your website. Is that something that is yours as proprietary, or is that like tell me a little bit more about what it is you have?
That is, yeah, yeah. So that is one that we developed ourselves with a manufacturing partner. Went through a lot of iterations. Just did a firmware upgrade on it. We do a lot of work with our customers, taking their feedback to understand exactly what they're looking for. I wear an Apple Watch, right? It's great for me. I get a ton of data from it, love it. But it is pretty complex. I mean, it's almost so complex that I'll be honest with you, I actually did this weekend. I just shut it down where it's like I get no notifications. It just like monitors my sleep, monitors my activity, and sometimes I press it and see what time it is, right? It's like as simple as it can be. And I love it. And that's kind of where ours is, right? It does a step count, it does your heart rate, gives you the weather, but it's very straightforward. It's very simple. And then, if you fall, it automatically goes off. It's got automatic fall detection, but then also you can press it and get help. You can be connected to your nurse. We've got nurses that are on our team that you just press it. It goes to our operators. They'll triage the situation and then escalate it to a nurse, and then we can connect you to your physician or whatever other help you need. We can set you up there.
Wow. Well, and that gets to the point, as you said, that's so much more discreet. In fact, it looks normal, right? I mean, like,
Yeah, I think that's really the key. And talking to a lot of our customers, we have a lot of resellers and work with a lot of home healthcare agencies. And that's really the biggest thing. People just don't like that stigma. One of the home healthcare agencies I was talking to recently had a really good analog for it, and they said, it's the caregiver when the caregiver's not there. And so literally, somebody's in the home for maybe 4, 6, 8 hours during the day. They leave. It's like, all right, I'm going to put this on your wrist. It's going to connect to a device. We've got different devices, either the cellular radios in the device, like a smartwatch, or the device sits on the countertop, whatever it might be, and then they would press it, it would activate that device. And so those batteries on those devices, they last like 3 years. So as long as you're wearing it, it'll go off automatically if you fall, and then if you press it, it'll be connected to the device that might be 50 feet away from you, but we can still hear you from it, dispatch help.
so this question may seem a little bit out of left field, but we're really not too far from this concept, which as I hear you talk about that caregiver when the caregiver isn't there, within 5 to 10 years at the most, we're going to have probably humanoid robots in the home for situations like this. Now, I wouldn't think you're actually working on that today, but I mean, are you thinking about that, or is that stuff that comes up in your industry? How are people starting to think about?
Yeah, I was at a conference, Beata Home Care.
Mm-hmm.
Yeah, yeah, David Beata, he was speaking, and he said the same exact thing. I mean, look, the baby boomers, the oldest baby boomers turned 80 this year, right? 1946 to 2026.
Okay.
So when you think about it, like everybody's been talking about the silver tsunami, it hasn't really hit yet,
Yeah.
right? These guys are
Right.
healthier than prior generations. They're going to live longer. My in-laws are, and going to the gym, working out, right? They're probably honestly probably healthier than I am. And so, I'm thinking about like, man, when are they going to need PERS, or when are they going to need healthcare, or somebody in the home? It's probably going to be a while. So, but like you're going to, there's not enough human beings to do this work. Right. And so with the immigration issues, you're not going to bring people in right now with this administration to do that work. So what's left? David Beata was talking about it, and I think it's a couple years. I don't think it's 5 or 10 years. I mean, you look at some of these robots that they've got now; they're not expensive, right? I think what Tesla's doing is unbelievable, and there's so many, Boston Robotics and everything. There's so many other companies that are doing this, but they're like 20 grand, 25 grand. You think about that cost up front for a home healthcare agency to go, buy a bunch of robots, and so I do think technology will be the solution, whether it's ambient monitoring or actually a humanoid robot or whatever it might be. Yeah, there's going to be a crush of resources needed in the next 5, 10, 20 years. And I don't know how you respond with human beings to do that work.
Right, right. Well, but you highlight, even though 20 grand might not be expensive, in our terms of thinking of robot, for 58 million seniors, right? It's a lot. So, the technology, I've realized, exists to do just about everything. It's more about adoption and really like to be able to afford it. So I noticed one thing you were talking about recently in 2026, that the reimbursement, or the financial support for tech enabled care, you think that's something that's on horizon, especially with this new, I guess it's called the access model from
Mm.
CMS. So I'd love to hear. Yeah, I wasn't familiar with that. Tell us how you think maybe payers, the government's going to be more interested in this type of care, and how we can maximize that.
Yeah, I don't think the family would buy those robots, right? I think what's going to happen is you're going to have sort of two classes of care. You're going to have, okay, you can have the human care, and it's going to be whatever it is now. I think it's $35 an hour, whatever they like normally charge
Sure.
in like Philly, for instance. And then I think you're going to have, hey, well, we can also do technology care or whatever it might be. There's different packages, right? You've got PERS, you've got an ambient monitor that goes in the house and can track heart rate and breathing, and if there's a fall or anything like that. Those ambient monitors are already around. They're not that expensive. You're maybe looking at like cover a house with like 3 or 4 rooms or like an apartment.
Hmm.
Maybe you're going to spend like $500
Wow.
for the equipment, or $1,000, and then maybe like
Run cost.
$50 a month. Yeah. And then I think you're gonna have these home healthcare agencies like Beata, which will have humanoid robots, right? And it's like, all right, well, it's not 35 an hour, maybe it's 15 an hour or 20 an hour. And if the reimbursement follows it, I think you'll see it first come out in private pay, right? And then you'll see the government follow that later and say like, all right, this is actually legitimate. Somebody can have this, and maybe it's like Medicare covers this and Medicaid covers that, or whatever it might be. Yeah, yeah. I don't think it's that far away. Now the access model is really interesting. So have you seen the reimbursements just got released last week for what the actual reimbursement numbers are going to be for it? It's not, so like I originally thought like, oh, this is going to be value-based care. It's we're going to get whatever it is, $50, $100 a month. It's going to be like all this reimbursement, and it's really small. It's like maybe $240 per year for the full reimbursement. So it's like $20 a month.
So, that would be if you have a patient enrolled in a remote monitoring program, no matter how you're doing it, you're gonna get a flat fee of $240.
Yeah, and you can't bill fee for service for those patients. So you're going at risk.
Ah.
And then I think it's either the maybe the first 6 months you get the full rack rate, and then the like second year, or the months 12 through 18, you get like a 50% reimbursement. And don't quote me on this. I've just
Yeah,
been
no,
reading it like all this
sure.
weekend, but basically I think everybody looked and they were like, oh, that's not at all what we thought it was. And so immediately everybody starts looking at it like, okay, well, this can't be humans or doctors or clinicians or anything like that. This is going to have to just be technology. And so I think what it is the access model will be paired with clinical work, but I think it's going to be like apps. It's going to be AI. It's going to be anything they can do. And the government's going to hope that people make bets on, hey, how can I keep a hypertension patient healthy? How can I keep a CHF patient healthier to reduce the total cost of care with some type of technology, some type of app, some type of, I don't know.
Do you think they will try to do it with cost of care total, or do you because the lowest hanging fruit is always hospital admissions, ER visits, right? I mean, just from your experience, what do you think is the best way if there's someone listening who's developing something, right? This app is going to make somebody better, but I need to get paid for it. How would you kind of nudge them in a direction?
I think it's got to be AI. You look at like Dr. Oz and everybody at CMS. I mean, they're really pushing for technology, and just like we talked about before, I think you know human workers, clinicians, there's just not enough of them, and so it's like, hey, who can go take this moonshot and build something? I don't know what it's going to be. If it's something that's on your smartwatch or it's something that's on your phone, but maybe it's not even maybe it's deviceless, right? Maybe it's like, okay, I'm going to have my AI call you once a day and do a full diagnostic over the phone of how you're feeling, and it's going to track it over time. And the cost is really limited because all I have to do is pay for tokens of AI, but it's going to have to be totally automated.
So, along those lines, from where you sit, you see again people at their highest risk environments, or in many, well, you have the chronic care management, but certainly on the per side, right? The worst things that can happen to them where technology can make a difference. If you're sitting in a room with a developer and they can build whatever you want, and they say can do it in 3 years, what would it be? What would move the needle the most from your perspective?
I mean, I do think chronic heart failure to me is the lowest hanging fruit. Just like
Uh-huh.
looking at everything, I think it's the greatest cost to the system it's probably the most acute issue that you can try to fix quickly, right? I think it's probably going to have to be something. I mean, you can't have a huge cost for the hardware, right? Just with this reimbursement rate. So it's got to be something that is deviceless, and I think it's probably going to be some type of like companion or some type of coach that everyone can use. I think everyone has a phone, everyone has a television. Maybe you don't have some crazy hardware, but hopefully they have a smart TV, and you can, put an app on that and they can connect to an AI that can get eyes on. Maybe. I think a lot of it, video I think is overrated in general with telehealth. I think a lot of good work can be done over audio and voice, and so it's probably something that speaks to the patient, and is over telephone, and is some type of like AI automation. I think what's going to be difficult is like, how do you put the right guardrails in place so that it
Exactly.
doesn't go too far, it knows when to escalate, and it doesn't, hallucinations are kept to a minimum. But I just think in the last year, that from what I've seen, we're processing 300,000 calls a month through AI and through natural language processing. It's unbelievable, the advancements, and I feel like we're just in like the first or second inning in this game, and so.
For sure. Many of the people who are developing things that I see, they still are very thoughtful about keeping a human in the loop.
Hmm.
But then the feedback they get is, yeah, we do that. But yet the models are so good, and in many respects, can triage things more effectively and even sometimes faster than humans. So I want to give you a chance to sort of reach someone before they need a PERS, or that they don't have the event that a PERS would have made a difference, like that guy I talked to today, or even around the remote monitoring. What's the kind of you bump into someone in the coffee shop and you get a chance to tell them, hey, this is why you should really think about this. How do you make the case?
I think if you look at how do you intervene before something happens, right? I think it's looking at that deterioration and just seeing trending data over time. What does this look like longitudinally? And let's say, for instance, you set up something that it's more of a companion, maybe it's less clinical, and it just talks to someone. Maybe they talk to it. The thought was, and there are already some of these platforms out there where somebody can just uh, talk to they talk to an AI, and it's either like a journal or maybe they're doing some type of like memoir or just asking them questions. If you layer over natural language processing over that with machine learning, I mean, you can definitely see, I wouldn't say early onset Alzheimer's, but at
Yeah.
least dementia
Pick up
over
the warning
time.
sign.
Yeah, yeah, exactly. And I think some of those things, that's where you'll see deterioration. The biggest thing is just, keeping them using it over time, right? So maybe it's something where they're like playing a game, or I know my mother-in-law loves Wordle, right? She's in it every day, and like all those games from the New York Times. maybe it's something like that, but in the background, it's tracking like, all right, were they as fast as they were a week ago? What's actually happening here? And you can kind of see that over time. That would be the one thing I think would be really, really interesting, but I haven't seen anybody really release anything that's at scale yet.
Cool. Well, I'll tell you, it's fun to be using technology and be part of technology and building technology. And so like this stuff is interesting to begin with, but it's great to meet someone and have a chance to chat with someone who, again, is really taking this stuff and intervening at the moment when it matters the most. So I really appreciate the work you're doing. It's great learning about it. I'll certainly be following along. If anyone wants to learn more about Connect America, what should they do?
Yeah, definitely check out connectamerica.com. I'm on LinkedIn. You can link in with me there. We post a lot of great stuff. We're on all the different social media platforms, but I think check out connectamerica.com and you can keep up with us right there.
And I'll be looking for the humanoid robots on your site within 3 years.
Absolutely. Mark it down.
Aaron, thank you so much. Great visiting with you today.
Thank you, William. Have a great day.
I will. And to everyone else, thank you for joining us on Healthcare Algorythm. Hope to see you next time. And until then, be well.